Our next presentation is Management of Retinal Detachment Without Vitrectomy Adjuvants by Mark Johnson from Ann Arbor.
Thank you, Gary. I'd like to thank Eric Schneider and Ryan Garretts for their contributions to this and say that none of us have financial interests in this topic. For the repair of primary uncomplicated retinal detachment, there is broad consensus that scleral buckling is preferred for young eyes without PVD, but that vitrectomy has a dominant role for other cases. What remains uncertain is the benefit of vitrectomy adjuvant procedures, such as scleral buckling, encircling laser retinopexy, or the routine use of heavy liquids. We hypothesize that considering the pathogenesis of rhegmatogenous detachment, one should achieve a high success rate by accomplishing two surgical objectives. One is the elimination of dynamic vitreous traction, and the other is identification and treatment of all retinal breaks. We further hypothesize that given equivalent outcomes, the simplest procedure is the best procedure because it avoids the cost and morbidity of unnecessary measures. So we sought to analyze to test this hypothesis, we sought to analyze the anatomical and functional outcomes of a consecutive series of primary uncomplicated RDs treated with vitrectomy alone without adjuvant procedures. This was a retrospective, non-comparative series by a single surgeon whose standard approach to non-complex RD was either scleral buckling in young eyes without PVD or vitrectomy, but not both. We looked at consecutive patients undergoing vitrectomy for detachment and limited the analysis to primary uncomplicated detachment. So we excluded eyes with previous vitreoretinal surgery, complex detachments, or less than 6 months follow-up. The surgical technique involved wide-angle viewing, a thorough but not necessarily aggressive trimming of the vitreous skirt, with special attention to retinal breaks and the sclerotomies. Extensive scleral depression, interestingly, was used only in about 38% of these eyes. We undertook a meticulous search for all retinal breaks, and I think this is the most important part of the procedure. All breaks and suspicious lesions were treated. We used cryotherapy prior to fluid gas exchange for most small anterior breaks, endolaser for others, and there was no prophylactic treatment of normal retina. We performed endodrainage and C3F8 gas with careful postoperative positioning with attention to the breaks. Heavy liquid was used only for excessive retinal mobility in 2 eyes, and no eyes received scleral buckling. The baseline characteristics were representative. The mean age was 60. Just over half the patients had a macula involving detachment. Just under half had phakia, and inferior breaks were present in over a third. In terms of anatomical outcomes over a mean follow-up of 31 months, the single operation success rate was 96%, and this rate did not vary by lens status or macular status. We looked at the primary anatomic failures and found that the causes of recurrent retinal detachment after the initial surgery included PVR in 3 eyes, incomplete closure of the pathogenic break in 1 eye, and we found no new retinal breaks in any eye in the absence of PVR. A single operation was successful in 3 eyes, and scleral buckling was employed in 2 cases with PVR. There was a highly significant improvement in visual acuity, with 77% of eyes achieving 20/40 or better at final follow-up. And notably, the complication rate was very low, with CME and PVR in 3% each, and ERM and glaucoma in 2% each. I wanted to highlight 2 comparative studies that were presented at last month's Retina Society. The first, by Tabanda and colleagues, was a retrospective single surgeon case series of 300 eyes, and he found a single surgery reattachment rate that was identical for vitrectomy alone compared to vitrectomy and scleral buckling. The second, by Wang and colleagues, was a multi-center retrospective study of over 2,000 eyes, and they found that use of encircling laser retinopexy did not improve the single surgery success rate, but was associated with lower final anatomical success and worse final visual acuity. So why do surgeons use adjuncts to vitrectomy? I've heard a number of reasons, and I frankly don't buy any of them, but let's go through them. One is that you need to treat missed retinal breaks, and that may be true if you miss them, but with emphasis on meticulous intraoperative searching, we found no cases of recurrent detachment from missed breaks. And we believe, therefore, that a careful search during surgery is preferable to the morbidity of routine scleral buckling or 360 laser. The second would be to prevent new retinal breaks from postoperative vitreous-based contraction. But we saw no new breaks or other evidence of vitreous-based contraction in the absence of frank PVR, and Castillo reported recently similar findings in a series of 267 eyes, and this challenges the need to support the vitreous base with buckling or to perform 360 laser. And then finally, people talk about treating inferior breaks, but our study and others show excellent results without adjuvant procedure in these cases. So it appears that adjunctive procedures are unnecessary but also potentially harmful. We know that scleral buckling is potentially complicated by postoperative pain, induced myopia, strabismus, scleral perforation, explant infection or extrusion. 360 laser has been associated with lower final anatomical and visual outcomes, increased rates of PVR and macular pucker, and complex recurrent RDs when they happen. And then the use of the routine use of PFCL certainly carries the risk of subfoveal PFCL, corneal endothelial toxicity, and of course, increased cost. So for those who may be still skeptical, consider the number needed to treat argument. If we assume that an adjunct like scleral buckling could actually could be proven to raise the primary success rate from the 96% I showed here to something like 99%, and that's a big assumption, then to prevent one recurrent detachment, one would need to expose 33 patients to the morbidity and cost of scleral buckling, and in my mind, this does not seem justified. So in conclusion, when vitrectomy is chosen for the repair of primary uncomplicated retinal detachment, a thorough but simple vitrectomy is associated with high anatomic and functional success rates and low complication rates. Adjuvant procedures such as scleral buckling, 360 laser, and routine use of PFCL are unnecessary in eyes without PVR or significant risk factors for PVR. Such adjuncts unnecessarily increase the cost and/or morbidity of the procedure. And finally, in the absence of frank postoperative PVR, contraction of the vitreous base is not a clinically relevant phenomenon. Thank you very much.
Thanks, Mark.